Hello, my name is Eilish Hildebrand. I am a product manager for routine diagnostics at Stem Cell Technologies, and I would like to welcome you to today's webinar. It is my pleasure to introduce today's speaker, Dr. Ahmed Mustafa. Dr. Mustafa is the clinical director of the Histocompatibility and Immunogenetics Lab at St. Paul's Hospital. He is also an assistant professor at the University of Saskatchewan. Today's topic is Unlocking New Horizons, exploring the vitality of lineage-specific chimerism analysis after hematopoietic stem cell transplantation.
I will explain briefly the principle of chimerism in stem cell transplant. In the second half of the talk, I will focus on validation of cell lineage isolation for chimerism testing. And at the end, I will wrap up the presentation with some case studies. Now let's focus on stem cell transplant and learn more about the principle of chimerism. At some points, healthy individual may develop a disease state like leukemia, seen as red cells in the cartoon. Then they receive some sort of treatment, and after treatment, they should have decreased in their immune system. Now the donor cells come along, have blue cells in the cartoon, and this donor replaces the immune system of the patient. If you have a complete chimerism, then the immune system is completely from the donor, and theoretically you should not have any further problem. But of course this is real life, so you may have mixed chimerism where either the recipient regular cells come back, or in the worst case scenario, the cancer cells come back. So how we evaluate chimerism in post-transplant patient? This is done by taking a DNA sample from the post-transplant setting and compare it to the pre-transplant setting, which is known as the genomic sample. So in the next part of this presentation, I will talk about our lab validation for cell lineage for chimerism testing. In our lab, and in order to increase the sensitivity of our assay, we use cell enrichment method. So if you directly isolate DNA from the whole blood, this is called unfractionated DNA. If you isolated CD3 from the whole blood, then extracted DNA, then the DNA will be coming from the T cells only. If you isolated CD33, CD66 from the whole blood and extract DNA, then the DNA will be coming from the myeloid cells only. And manual cell isolation is not as simple as I just showed you in the previous slide. The process is very tedious and it takes almost 45 minutes to isolate one cell subset. So if two patients came in the same day, then this will be approximately 3 hours hands-on time. Sometimes we even get 3 patients in one single day. So the story started in 2021 when I met Michael at the ASHI meeting and I was complaining about the manual cell subsets isolation. Michael started to introduce the Robosep to me and I was impressed by the amount of time that we can save. He even convinced me that by bringing Robosep, it can reduce the hands-on time to only 5 minutes compared to 3 hours that I have previously shown you. And here is the picture of the Robosep. The Robosep is basically a liquid handler that can do automatic cell isolation for up to 4 cell subsets at the same time. And you can tell here that our tech already fell in love with it. Another procedure that I found that actually significantly reduced the hands-on time was using this microscope. So in the past, we used to count the cells using a microscope and the hemocytometer, then the calculator to calculate the concentration. This process takes almost 10 minutes to be completed per sample. To be more efficient, this is replaced now by the Countess cell counter, where you can get result in under a minute. From the screen, you can visualize the live and the dead cells. In addition, it can give you the final concentration of the white blood cells. Our initial inquiry was focused on determining the optimal collection tube. So we compared the EDTA as a collection tube and compared to the ACD tube. After testing both the EDTA and the ACD tube, it became evident that the ACD effectively preserves cells compared to the EDTA. The EDTA tubes resulted in approximately 25% dead cells, whereas cells collected in the ACT tube exhibited 100% viability. All our future experiment, we were focusing on ACD-only tubes to complete the validation. And here we did a comparative analysis of cell count between the manual technique and the Robosep. The figure clearly illustrates that Robosep consistently yielded a significantly higher absolute cell count in both myeloid and lymphoid lineage compared to the manual method. We next wanted to validate our lymphocyte isolation. So we used here the negative selection kit from stem cells. We then conducted a comparison of cell purity for the total lymphocyte between the manual cell isolation and the Robosep using the flow cytometry. And examining the side versus forward scatter, it is evident that the purity of our lymphocyte was consistently above 88% for both methods, while the population isolated by the Robosep exhibited a denser distribution due to higher yield. And if you like graphs, I added a graph representation here to confirm to you that the cell purity were almost identical between the Robosep and the manual cell isolation. And for the T cells isolation, we use the CD3 positive selection kit. And to assess the purity, we used a bunch of different antibodies. We used the CD45PE, which labeled all the hematopoietic cells except the erythrocyte. Additionally, we used the CD2 and the CD5 was performed. So first, we gated on the CD45 cells so that we can isolate all or get on all the white blood cells. And then we took this population further to confirm that this population is consistently mainly of our T lymphocyte. And here you can see we use the CD2 and the CD5 antibodies. The reason we didn't use the CD3 as an antibody because the positive selection used the CD3 antibodies for pulling up the T cells by the magnet. So now the binding site of the CD3 on the antigen has already been occupied. So in that case, we use a different antibodies to pull or to confirm the cell purity by using the CD2 and the CD5. And you can see that the population or the purity of our cells is almost 99.6% pure. And upon comparing the manual procedure to the Robosep procedure, it became evident that the cell purities were nearly identical. I gated on the entire population to ensure that the cells outside the gate are not white blood cells, thus confirming their negligible impact on our downstream application. A comparison of the CD45 between the two figures revealed consistent cell purity. For those who prefer visual representation, I have graphed the result to highlight the closeness of the findings. Myeloid cells were isolated using the CD66 CD33 positive selection kit. Purity assessment involved staining the cells with CD45PA, and furthermore, the cells were stained by CD14 and CD66, targeting the monocyte and the granulocyte respectively. After isolating the white blood cells with the CD45, gating on the CD66 and CD14 population demonstrated an impressive purity of nearly 99.6%, considering both monocyte and granulocyte. And upon comparing the manual procedure to the Robosep procedure, it became evident that the cell purity were nearly identical. I also gated on the entire population to ensure that the cells outside the gate are not white blood cells, thus confirming the negligible impact on our downstream application. A comparison of the CD45 between the two figures revealed consistent cell purity. For those, again, who prefer the visual representation, I put them all in one graph to confirm that both are very close findings. Now, in the last part of this talk, I will focus on some of the case presentation. In our first case, which is a case of a subset chimerism, These actually are two different patients, patient 1 and patient 2. So if the physician is looking at only the unfractionated cells and see 100% in patient 1 or 99.4 in patient 2, and most of the lab will report 99.4 as 100% due to assay sensitivity, the physician will think that the patient are doing really well. But looking at the T cells in patient 2, it's actually a case of mixed chimerism, because patient 2 has 5.9% of host cells coming back. This can be indicative of or a start of a graft failure. In addition, looking at different cell subsets are of a significant value rather than just looking at the whole unfractionated blood. So case 1 is a clear case of a subset chimerism, which is defined as mixed chimerism in one cell type and the presence of recipient-only or donor-only derived cells in the other. This could be an early time point after engraftment or could be a start of relapse. In case 2, which is a microchimerism in cell subset, when you look at the percentage of donor cells and the host cells in the unfractionated sample of the post-transplant patient, the total must be 100. But in that case, it was only 99.6%. So where is the remaining 0.4%? Let's see the rest of the lineage to understand what's going on. In the myeloid lineage subset, the total is 100% and all are donor. So the problem is not here. Now, when you look at the lymphoid lineage, you can see that the total is 97%. And again, there is a missing 3%. When we dug more into this patient, we knew that the patient was transplanted previously and had a failed transplant. When we added the DNA of his first donor to the analysis, we found that 3% originate from the failed transplant of the first donor. Let's see how can I explain this case much better. So conclusion of this case is actually a case of a microchimerism in the cell subset. As you see in the figure, microchimerism is the presence of small number of cells in an individual that have originated from another individual and are therefore genetically distinct. So this patient was transplanted by the red cells, and after the transplant failed, he received another transplant from the blue cells. Most of the red cells are gone, but few remains, which is known as microchimerism. In case 3, which is a case of a split chimerism, in this case you can see that the patient has completely lost the myeloid lineage while remain some of their lymphoid lineage. And if you look at the graph trend over time, shows gradual loss of the myeloid lineage as seen as the orange line, and you can see that the lymphoid lineage seen in the blue line had barely changed over time. So this is actually a case of a split chimerism, which is a complete or mixed chimerism in one cell type and the presence of recipient-derived cells in the other. This patient has a recurrence of acute myeloid leukemia. That's why all the donor myeloid cells was replaced by the cancer cells again. In case 4, which actually explain a case of a primary graft failure, the patient started to lose their graft by day 64. So chimerism and analysis can aid in the diagnosis of a case of a primary graft failure. And why primarily? Because none of the subset reach 100% donor chimerism and because of the short duration of engraftment. This is another case of a secondary graft failure. So comparing it to the previous case, this is a secondary graft failure because the myeloid lineage reached 100%, and then the patient started to lose graft as shown where the red arrow is pointing. Case 6, this is a case of a mixed chimerism across all lineage and over the entire of the disease progress as shown in the graph. So mixed chimerism could be due to either the recipient regular cells come back, or in the worst case scenario, the cancer cells come back. And here is a disclaimer that chimerism cannot tell you the cancer cells are coming back or the healthy cells are coming back. And this is known as a limitation of chimerism. This can be done by MRD, which is a PCR done using specific marker that expressed only on cancer cells. And here in this case, or case number 7, this can show you that this patient was not doing very well until day 244, where he received donor lymphocyte infusion, leading to subsequent progression of complete donor chimerism. So there is certain things that can affect the engraftment monitoring. Number one is the type of the disease and the donor characteristic, the intensity of the conditioning regimen, the sensitivity of different cell types to chemotherapy and radiation, the type of transplant, whether it's an umbilical cord or bone marrow or peripheral blood. Umbilical cord is much slower and peripheral blood is much faster. But again, peripheral blood, they have tendency to develop more graft versus host disease. And the dynamic changes in the chimerism level, immunosuppressive and donor lymphocyte infusion. What is the limitation of chimerism testing? And I already mentioned that chimerism cannot detect between host cells and malignant cells, and you need another test which is called the minimal residual disease that can be done by PCR that detects certain marker present in the cancer cells. So a combination of chimerism testing with minimal residual disease assay is the best way to detect relapse. And again, is the purity of your cell subset isolation. So in summary of using cell-specific lineage, it improves the sensitivity, the precision, the specificity of the assay. It can differentiate between subset chimerism, split chimerism, and mixed chimerism. It can differentiate between primary and secondary graft failure. It can predict graft versus host disease. It is important for monitoring of donor lymphocyte infusion, and it's important for early detection of relapse and detection of microchimerism.
Thank you, Dr. Mustafa, for your presentation. Before we conclude today, I'd like to discuss how stem cell can support your chimerism lab. I wanted to start off by highlighting stem cell support teams. Stem cell has excellent technical support and offers access to scientists for all of your technical needs. In addition, stem cell offers reliable product quality and availability. Now I'd like to speak further to the advantages of some of the EasySep products that were discussed by Dr. Mustafa. With EasySep, you're able to isolate highly pure subsets, and while chimerism labs generally prefer positive selection, both positive and negative selection kits are available for purchase. With EasySep, there is no risk of cross-contamination because the protocol calls for single-use tubes and there are no shared surfaces, and this is true for both manual and automated isolation. Another benefit of EasySep is there is no to minimal sample preparation involved in the protocol. As Dr. Mustafa mentioned, automating your workflow can result in time savings and therefore allows labs to increase their testing throughput. Here we have the EasySep HLA Chimerism Whole Blood Positive Selection suite of products to support isolation of hematopoietic lineages. All kits will provide high purity of isolated cell subsets, regardless of whether you're using a manual or automated method. And with that, I'd like to conclude today's webinar. I'd like to thank Dr. Mustafa again for the wonderful presentation, and also thank you for watching this webinar. I hope you have an excellent rest of your day.